Good morning. My name is Ann Brazo. For most of you for many of you that may not know me, I was with the MPN Research Foundation when the JAK2 mutation was discovered in 2005, thereabouts. I've been in the space forever. In 2013, I left the foundation to focus on education and advocacy while they continue to focus their efforts on research. We are in Michigan, freezing, but actually the temperatures are going up a little bit today. And I want to welcome all of you. We have been doing many of these programs over the last year since the pandemic hit us all very hard. And I'm very proud of the fact that we've been able to stay in touch with our patients. And we had dedicated this month to focusing on the 3 MPNs specifically. We talked about MF last week. Today we're going to talk about Polycythemia Vera. We have tons of questions for our 2 speakers. And I would like to introduce, or first of all, I'd like to thank our sponsors and our industry partners who are fantastic. We would not be able to do any of this without their help. You'll see the slide there. I can't name them all at the moment, but we will recognize them later in this program. They are wonderful. It's wonderful to have that relationship and get their assistance in hosting these programs. I'd first like to introduce Dr. Aaron Gerds from the Cleveland Clinic. And Aaron's been with us so many times and we just love him. And it's been great to have him with us because you can ask anything you need to know and he will be very happy to answer. But we're first going to hear from Aaron on what's happening at Cleveland Clinic and some thoughts about PV and that he would like to share with all of us. Dr. Gerds?
Well, thanks so much, Ann and Kathleen and Naveen. It's always a pleasure. And thank you all for logging in today to discuss or have this fireside chat, if you will, about Polycythemia Vera. Certainly, as Ann mentioned, this global pandemic we're all facing has changed things quite a bit in the way we think about delivering care to patients with Polycythemia Vera amongst all the MPNs. I could say that in my own practice, you were doing a lot more virtually, virtual visits. Even within the context of clinical trials, we're doing more virtually. Local labs being sent into us, as well as virtual visits with the nurses and for their nurse visits. So definitely the mode of delivering care has changed. We're all attuned to seeing what happens when patients with Polycythemia Vera and other MPNs get COVID, and how can we prevent it, and how can we prevent complications from the disease too. So again, a lot has changed in the last year. The thing that has not changed, I would say, is our desire and our drive to better the lives of patients with Polycythemia Vera. And not only are the preclinical, translational, the lab studies, where we're growing PV cells in a dish and doing experiments on them, those things are continuing. But more importantly, we are continuing to do clinical trials and move therapies into the clinic for patients. And potentially this year we could have a new drug approved for PV even, which is very, very exciting. So, in spite of this whole pandemic thing that's going on and the weather-related calamities and all these things, the civil unrest in the country, I think it's really amazing that there's a group of people dedicated to taking care of patients with MPNs and making their lives better. So certainly here at the Cleveland Clinic, we're experiencing all those things, but yet continuing to take care of patients and improve their lives through research and clinical trials. So I say things are not normal, but they are normal.
Yeah. Okay, thank you, Dr. Gerds. And our other physician and researcher joining us is Dr. Naveen Pemmaraju from MD Anderson in Houston, who, where Houston had this bizarre weather, and thankfully he's with us today. And again, one of our real good buddies and pals, and he's a fabulous physician, and I know some of you know him and probably see him. But Dr. Pemmaraju, what would you add to what Aaron had to say here today?
Well, thank you, first of all, and to you, Kathleen, and your team for your advocacy, both before the pandemic and now, even more important than ever, the virtual formats that you and some of your colleagues pioneered. I know we'll be in person again soon for the town halls that you have started, but thank you for continuing your work and education and spreading the word during these troubling times. To Dr. Aaron Gerds, my friend, my colleague, it's actually an honor to be able to join you, because I haven't seen you in person, I guess, in over a year. So I'm missing you.
Wow.
So seeing your bow tie and your face and your jacket, it kind of livens up the day. So I just want to say that. To our patients out there and caregivers and loved ones, what an awful last year and a half it's been for everyone, as both you and Aaron alluded to, everything from the pandemic to what's going on in society for many of us, and now with the winter weather and just things, just what else can each day bring? On top of that, our patients with MPNs already were facing an uphill battle. I think in the myeloproliferative space for P. Vera, as we meet today, Aaron really hit on some nice points. I think lots of excitement to bring to people as we head into 2021 and 2022. 3 areas I would focus on. Number 1 is new drugs, as Dr. Gerds mentioned. I'm actually surprised. It's been decades since we've had anything besides hydroxyurea and the standard formulations of interferon. And I'm sure we'll talk about it all here, but there is a new form of interferon that's already been approved in Europe that Aaron was mentioning. This is the ropegylated interferon, aka Bezremi. It has a name already over there, and we're hoping, fingers crossed, to get it over here and approved as soon as this year. So let's all keep track of that. Should have less side effects than the standard Pegasus interferon, less dosing interval, so every 2 weeks to every month, and has 5-year long-term data. There is a second drug program focusing on something that Aaron and I have been following, a field about iron balance and iron homeostasis. So if PV and certain disorders have too much or too little iron, that can affect the blood count, and that's called PTG 300, and that's been presented publicly as well in the meeting. So I want our viewers to follow that as well. It's basically a hepcide mimetic and makes the iron balance a little bit better in our patients. So new drugs for the first time in, I would say, decades. Number 2 bucket, as we start together here, is focusing on molecular mutations. So, Anne, as most of our viewers know, different centers check different molecular tests. So the big 3 in MPNs are JAK2, CALR, MPL. In P. Vera, of course, it's really all JAK2. But outside of that, as Aaron's group, my group, and others have shown, there are other mutations out there. So ASXL1, you wouldn't have to get focused on the alphabet soup of it, but some of those may help to guide if people are higher risk than others. And then the third bucket is COVID-19, as Aaron definitely mentioned. I love what you said about telehealth, and you are now the lead editor of the ASH Clinical News. You've written very nicely about some of these topics, you and your colleagues. But the other key thing is that there was a big study out of Europe from Dr. Barboui that showed that people who have MPN and are on Ruxo should not abruptly stop their Ruxo, because those patients had a higher death rate or mortality with the COVID-19. So early on in the pandemic, there were reports of patients abruptly stopping their medicine out of fear, or supply chains being messed up, or even doctors stopping it. But now we know, if you're on one of these medicines in general, right, in particular, speak to your own doctor, but in general, you can stay on those medicines. So, Anne, back to you, but there's a lot going on, most of it good for our patients with PV and MPN, even in these tough times.
So you certainly have hit on a array of things that we need to discuss today. And I have, as I said, I have this long list of questions from over 250 registrants. So let's talk about COVID for a moment, and then telehealth. And every recommendation we've heard from many of your colleagues and yourselves, I believe, is definitely get the vaccine. If it's available to you, get the vaccine. You just mentioned some data or some information from Italy. Are you seeing anything in your practices that would indicate that MPN patients are having a harder time with the COVID vaccine, or is there anything standing out to you that you would make other suggestions? Dr. Gerds?
Yeah, thanks for that question, and it's one I get often. Simply, should I get it? What should I do if I get it? Should I stop my medicine? Should I continue it? It's really kind of unclear. I just don't think we have the experience yet, and can gather large amounts of data and information on people who've received the vaccine so far, because few have received it. Here in Ohio, if we look at the total population of this state, we're less than 10% of the state vaccinated so far, closer to 5 than we are to 10. And so there's just not enough information out there. We have some, I have some anecdotal experiences with the vaccine. Now, it seems the patients that I've had who are on ruxolitinib and who are on hydroxyurea have done pretty well with the vaccine and exactly kind of fall in line with what we'd expect based on the clinical trial results. I did have an anecdotal experience of one patient having kind of an exuberant reaction when they got the vaccine after taking pegylated interferon. So this is a patient who's been on pegylated interferon for a while, took their dose the day before they got the vaccine the next day, and then the first dose of the mRNA vaccine, and then had pretty significant fevers and body aches and were sick for a couple of days. Now that could just be the vaccine, or it could be it could have been something augmented by the peg interferon. So for that particular individual, for their second shot, we're going to give them a nice window. There's patients who are really stable on their pegylated interferon. We can interrupt treatment temporarily to do something like this. So I've started talking with patients saying, this might be something we want to think about. I don't know if this is real, if it's an anecdote, but it certainly wouldn't hurt to skip a couple of doses of peg interferon while we do your vaccination, because that's important. Getting COVID, even if you're young, healthy, don't have any other medical problems, it can be very serious and you can die from that. Right. Where skipping a couple doses of pegylated interferon when you're under good counts control probably isn't going to make a difference, especially now since we have the data from France in the discontinuation study.
Okay, and okay, I do have friends that do not have an MPN that have had the same symptoms after a shot. So
and it happens.
But as you said, there's no data. There's nothing. There isn't enough information. Dr. Pemmaraju, do you have anything to add to that or your experience?
Agree with all of that. Here at Anderson, we've had a very nice experience so far, as you said, anecdotally with the rollout. I think it's kind of a nice way, sort of started out with the frontline employees, nurses, doctors, and making sure that it was safe and feasible to give. So either Pfizer or Moderna, the mRNA vaccines that are available, and then moved quickly into patients and even patients' loved ones if they qualify. I really appreciate what Aaron said, because you're right. Our patients, the ones that are listening right now, the ones at our centers, are the very first patients in the world to really get the vaccine with PV on interferon or MF on Ruxo. So let's see how it goes. It has been going well so far. I've been happy. I think what Aaron said is important. New England Journal this week and has a review article on patients and people, actually really healthy volunteers and people getting allergic and other reactions to the vaccine. So it is something, and I have seen that, as you said, in both healthy patients and those affected with MPNs. I think so. That's one concept. I think a second concept that we get asked about, let's put it out there. Hey, this is such new technology, mRNA, is it going to lead to second cancers and all that? Obviously we don't know. That's not comforting or reassuring to anybody. I'm amazed and happy with the science. Truthfully, the science has been around for a long time. So I know it seems like it's all of a sudden it just came out of nowhere, but like everything else, people have been working on this for 30 to 40 years. So I think necessity was the mother of invention, and it spurred the development of these miraculous vaccines. So sure, let's all watch together as we would in a clinical trial, as you would when you start a new prescription with your MPN doctor. Let's watch and make sure. But by and large, in the first few months, it has been very positive. I really appreciate, Aaron, what you said. Let's get everyone who it's appropriate for and you qualify to get vaccinated, because the virus is much worse. And I think for patients with maybe systemic mastocytosis or folks who have had to use an EpiPen before, possibly those folks may need to talk to their doctor and maybe have an allergist, immunologist involved and be followed a little bit closer for reactions. That's also part of the newest guidelines, is if you have a severe allergic history, that you want to do some planning there. So that might be one caveat, but by and large, let's get everyone vaccinated who can get it.
Great information, very great information. So let's talk about telemedicine for a second. So as a PV patient who is generally doing well, would you say, you just stay on the same protocols, do what you're doing, everything's fine, but what if I'm a PV patient who starts to feel sick? When should MPN patient or PV patient schedule an in-person meeting with their doctors. Aaron, do you want to go first?
Sure. So definitely, things have changed, and we're using telemedicine a lot more. And I think, yeah, for the general PV patient who's doing well, is kind of quote unquote on autopilot. Their dose is stable. Things that are not needing lots of phlebotomies. I think it's absolutely fine to do telemedicine. The one piece that I will say that is, other than the face-to-face or mask-to-mask interaction that we can have, is really examining the spleen. That's the one thing you can't do via telemedicine yet. Maybe we'll have robots in the future that can do that for us, but not right now. And so I think that's part of the monitoring process that we just can't do. But certainly if someone's experiencing changes in their disease, symptoms are emerging, their spleen might be they feel that their spleen's getting bigger, or it's difficult to take their medications, I would have a low threshold for coming in and seeing your doctor. It's pretty well documented that the protocols that hospitals and clinics have put into place to continue to deliver care, in-person care to patients, are protecting them. There are not instances of widespread outbreaks in clinics or patients coming in to see their doctor and then getting COVID from that. So really, I think it's a safe place to go and be seen in person by your doctor, certainly if you need it, but even for just routine care. I think we're at the point now where that is absolutely safe and acceptable. Now, there's a process sometimes getting to a doctor, and you may not want to venture out, and I think that's a fair thing too. And then I think that's really where, again, telemedicine can help. But if you're not doing well, you can't ignore your PV. It's going to come back to bite you in the future, and you really got to take care of that. And that's a message not only here at the Cleveland Clinic that we're spreading about all health conditions, whether it's hematologic disorders or heart disease or colonoscopies or breast cancer screening. You got to take care of yourself. Cancer still happens. Heart disease still happens. It's not all stopping because of the pandemic.
And I can speak firsthand to that because I did have to have a surgery last summer, a minor surgery, but nonetheless had to go to a hospital and go through the process. And I was very nervous and anxious about it, but everything was fine. They were so superb in how they cared, for the security of all the patients and the workers and physicians and so on. Dr. Pemmaraju, did you want to add anything to that?
I think this is an important question, Anne, that you bring up and our viewers, because there is a balance, as you and Aaron are saying. It has been very safe. I personally feel safe. I regularly ask my staff, now that we're 1 year into this, masking, face shields if it's appropriate, social distancing, there are ways to still do it, even in a busy, packed clinic. So I've been very, very happy with that, and I appreciate what both of you said. I think telehealth has positively revolutionized a lot of what we're doing. It should have been around before, let's say that, but again, necessity, mother of invention. I think telehealth will be here to stay in a very real way after the pandemic. But as you and Aaron mentioned, I think there's 3 or so categories that you miss with telehealth. One is, of course, the physical exam, the actual palpation, spleen, lymph node, all of that, which may be a dying art in and of itself, but still has utility, especially in the MPN and classical diseases. Number 2, there is a certain je ne sais quoi, if you will, an art of medicine that Anne, Aaron, you very well know, that I can tell within about 5 seconds of walking in a room, if I've met you once or twice before, I know exactly what's going on. I don't need a hemoglobin, I don't need a hematocrit. I know you're sick, you're about to go to the ER, you're okay, you're doing great. The 2-dimensional Zoom space misses that. Yes, I get to see you in your home environment and your pet, and that's great for the PV patient who's 10 years on Hydrea and doing well, but not for the change of status patient. And then the third aspect, of course, Aaron also mentioned, let's be honest, you can't do virtual bone marrows and virtual blood tests, so those still have to be done either at your center or somewhere. So I think that the in-person visit is overall rather safe. The benefit will outweigh the risk when it's needed. So a good mix, I would say, moving forward, even after the pandemic, if telehealth can be here to stay, may be optimal for most of our patients. Anne?
Okay, so I'm going to get to the pages of questions I have for you, gentlemen. Is a high hematocrit and low iron normal for PV? Aaron?
Okay, sure. Is a high hematocrit and low iron normal for PV? Well, you know, if we think about it, when we do phlebotomies to treat PV, we're really making people iron deficient. So by eliminating iron stores in the body, you can affect the iron axis. Hepcidin, for example, is a big part of that, as Naveen mentioned. And really, basically the thought is that if we deprive the bone marrow of iron, it can efficiently make red blood cells, and that's why we think it works. So we actually try to get people iron deficient in order to treat their disease. Now, some people can still have a high hematocrit despite being iron deficient. Their disease is that proliferative that the iron deficiency doesn't do the job. We need to think about additional therapy. So it definitely can happen. Although ideally, you know, when we get a low risk patient, we treat them with phlebotomies, we get them iron deficient and they're kind of in a good place, but sometimes that doesn't work and we still need to do additional therapies outside of phlebotomies.
Naveen, Dr. Pemmaraju, do you have anything to add to that?
Yeah, I think this is an important field where, you know, you've gone from the sort of old school, if you will, phlebotomy, which has been around before modern medicine, right? So that goes back to maybe even the Middle Ages, it appears, where phlebotomy was treated for everything, right, Aaron? So they used to have something called leeches, right? So this is real. This isn't an urban legend. So you go from leeches to phlebotomy to now PTG 300, right? So taking what Aaron said, now with the medicines that are coming out, you have some of these medicines, momelotinib in the myelofibrosis space, and that you know well, and then this PTG 300, there is this sort of hepcidin, mini hepcidin iron balance. It's kind of mystical and magical kind of science that we didn't learn, I don't think, in medical school, Aaron, but right. So can you now capture that not just by the simple phlebotomy, but in medicines and drugs, either injectables or orals, that can restore the balance of high iron and then therefore restore the balance of the hematocrit? And can it not just be numbers on a piece of paper, Ann and Aaron? In other words, can you now improve the symptom burden? Can you feel less tired? Can you have more energy? Can you have less blood clots? Do you have less of a chance of going to myelofibrosis and AML? Those are the research questions in the next 5 to 10 years. So I think this big question about iron balance and PV is going to be the dominant issue in the next 5 years.
Okay, should all PV patients be put on hydroxyurea or Jakafi to prevent progression and hopefully have a remission? Naveen, do you want to start?
I'll start with that one, Ann. Yeah, the short answer is no. So PV, interestingly, we're talking about all these great developments, but I'm glad this question came up. So we have to say it out loud that many of our patients, actually the majority, I should say, of our patients should be what's usually called the lower risk PV, although you should be under the age of 60 and no prior blood clots. So actually a lot of patients fall in high risk, but low risk PV traditionally has been under the age of 60, no prior blood clots. Those patients they will not need cytoreductive therapy, as our questioner is asking. So you will not need hydroxyurea, interferon, or ruxolitinib. Now, number two, in the advanced PV setting, if you are frontline PV in 2021, so over the age of 60, symptom burden, you know, thrombotic event, whatever your risk factor is, still really the frontline therapies are hydroxyurea and interferon, and we'll wait to see about these clinical trials. The ruxolitinib agent, which is approved in myelofibrosis, is in fact approved in PV, but I want to make a distinction. It's not approved in frontline yet. It's approved in second line advanced PV after hydroxyurea intolerance or failure. That's where the New England Journal data is. That's where the FDA approval is. So short answer, no, everyone does not need chemo in PV. And even if you do, you should meet certain high risk features, and you should have failed some of the standard therapies before moving to the JAK inhibitor. Ann?
Aaron, do you have anything to add to that?
No, that's a pretty great and thorough explanation, and I completely agree. You don't necessarily need to be on a medication to control your counts. And you know, I think the other kind of key piece of that is of the question was to prevent progression. You know, I think that's kind of a sticky wicket with a lot of the therapies that we have. We know hydroxyurea can control counts, so can ruxolitinib, can improve symptoms, but there's really no evidence that they can delay progression. Interferon's a little bit more murky water there. I mean, there are retrospective analyses that suggest a delay in progression, particularly myelofibrosis-free, you know, myelofibrosis progression. But you know, the retrospective studies, single institution, a lot of methodologic holes you could poke in those papers. But definitely, I think it's something that we are aiming to do with a lot of these new therapies that we're developing, is look at ways we can delay progression. But the key thing is, people with PV do well for a lot of people do very well for a long time, and we want to maintain that as much as possible and minimize complications of the disease.
So let's talk about the differences in JAK inhibitors, if you would. And that is, for the two that are available to our patients, what are the differences in Jakafi or ruxolitinib and in Ropepeg?
Right. So the ruxolitinib, which many of our viewers know about, ruxolitinib, trade name Jakafi Incyte, has been the first and foremost drug in the field for almost a decade now. First approved in myelofibrosis, as we mentioned, intermediate to high risk, now approved in advanced PV after hydroxyurea, as we said, and also a third approval, and is in acute graft versus host disease, so a little bit outside of our field, but people should know about that, and in clinical trials for a lot of different things. This is a JAK1, JAK2 inhibitor. We know it well. And by and large, well tolerated. There's been some signals of non-melanoma skin cancer, so you do have to follow for that. Many of my patients see a dermatologist, and it hasn't been a life-threatening thing for most patients. And then some hint at increased infections, such as viral infections like herpes zoster. But by and large, it's been a safe drug, and we have some good long-term follow-up now post 5 years. The new drug, though, that might be new and important to many out there is fedratinib or Ropepeg. This is a newly approved drug. Of course, as Aaron knows and you know, that's been around for a long time, almost 10 years itself from its earliest clinical trials, actually over 10 years. Also a JAK inhibitor. Both of these drugs hit slightly different other targets, but it's in the same class, as you said, of JAK2 inhibition. There is 3 keys, though, with the fedratinib. Number one is it had trials that were done in the frontline setting and in the relapsed after ruxolitinib. So the approval is broad. So it is actually approved. You could use it in brand new diagnosed or relapsed. So that's very nice. So there's flexibility there. Number two is that the big signal that came out in the clinical trials was that of encephalopathy or Wernicke's encephalopathy. And I want to explain what that is because it got an FDA black box label. It's a syndrome that can have neurological, so brain, maybe even thinking issues. The reanalysis showed that it may not have been exactly that it was instead more to do with malnutrition and a combination of having GI problems leading to the weakness and other things, but that is a black box warning. And then number 3, it can be addressed by checking thiamine levels, so a vitamin B level, and then giving thiamine while the patient is on the drug if it's needed. And again, watching out for these GI side effects, diarrhea, nausea, vomiting. So that's actually a very important signal for that drug. So in summary, you have 2 FDA-approved JAK inhibitors for myelofibrosis, ruxolitinib and fedratinib. The ruxolitinib has the approval for advanced PV. And then you have 2, 3, 4 other JAK inhibitors that are in the late stages of development, so-called phase 3. That's pacritinib, momelotinib, and others. So this is a class of drugs that's here to stay. Hopefully for our patients' option's sake, there'll be many more to choose from. And one thing we can ask Aaron about is what's going to be interesting for you and me is how do we sequence these drugs? And each of these new JAK inhibitors coming, Aaron, look like they hit a different niche area, whether it's anemia or thrombocytopenia. So how will we choose which one of these JAK inhibitors to pick?
Yeah.
And Aaron, I mean, before you answer that, if you'll remember that, because we look at anemia quite often, and we've heard about specialized treatment for each patient, and cocktail meds. So just to throw that in.
Yeah. No, and all these are great points, Naveen, and just to kind of reiterate, all the JAK inhibitors, they're all a little bit different, like you said, and it's not, and I really kind of think about it in two ways. One is the JAK inhibition that they're doing. Are they primarily JAK1, primarily JAK2? Are they hitting some of the other JAK-STAT pathway markers like TRYK and these other molecules? Because some are specific for JAK2, some are specific for JAK1, or both. And I think that can have an effect on what we see clinically when we use these JAK inhibitors. And the second part of that is what are they doing off target? Because it's important for both what it may be able to do to help patients and also important for side effects. So Again, fedratinib, there was the concern about Wernicke's encephalopathy, but in the clinic, what we really see a lot is GI upset, and because of the FLT3 inhibition that the drug has, it hits FLT3 on the side. And we see that to a certain degree with pacritinib as well as a FLT3 inhibitor. We do see diarrhea as a side effect. And then, of course, the positive effects of off-target, like ACVR1, hitting ACVR1, when momelotinib does that, it can improve anemia in patients. You know, in the grand scheme of things, I'm not sure how fedratinib as an already approved medication, as well as the other JAK inhibitors being developed, are going to treat polycythemia directly. I don't know if they're going to really cross over into that space. We have ruxolitinib, we have interferons, we have hydroxyurea, we have phlebotomies, maybe things like PTG300 and MDM2 inhibitors coming along, gavinostat. So I'm not sure I don't know if there's room for another JAK inhibitor in PV. Certainly myelofibrosis, definitely, and post-PV myelofibrosis, and you could easily see like ruxolitinib fitting a need of patients with like kind of higher platelets with myelofibrosis. You can see momelotinib coming in there for anemic patients with myelofibrosis and post-PV myelofibrosis. Pacritinib hitting that low platelet group, and fedratinib kind of filling the gaps, maybe the 50 to 100 platelets, maybe patients who have already had other JAK inhibitors or have some sort of maybe even a FLT3 signal going on. So you can see how they can all fit together and where there's a need for multiple JAK inhibitors. But I'm not sure we're going to have that much space in PV. And again, because there are so many more options and patients do relatively well with those options.
Awesome.
Yes. Okay. So should a woman with a hematocrit of 42 or 45 be having phlebotomies?
Aaron, go ahead. Yeah.
Yeah. Oh, yeah. This is a good question. So the infamous 42. It's kind of a touchy subject because I think there are people who really believe in 42. Right. But I think the challenge there is there's no real hard data to support that. There are some preclinical studies looking at cerebrovascular blood flow that was done many years ago. There's a whole concept that if you look at large groups of women, their hematocrit is slightly lower than the large groups of men. And that's really what that 42 is coming from. It's not coming from a well-done prospective trial showing that keeping women under a hematocrit under 42 makes them live any better or makes them live any longer. The real hard data we have is from the CytoPV trial, where it did show, completely conclusively, without any guesses or caveats, that if we keep the hematocrit under 45%, it does reduce the risk of blood clots and other consequences, and even potentially death from those blood clots. So that is where the hard data is. Now, there are many patients who are symptomatic at a hematocrit of 45 and feel better when their hematocrit is lower. And there's nothing wrong with keeping your hematocrit lower, and especially it can be beneficial for some patients who feel better with a lower hematocrit. But I think in terms of specifically reduce, a target to reduce blood clot risk, the best data we have is for 45. And I think that's what really sets that standard for both men and women.
And so if her hematocrit is at 45, she probably would not need to be phlebotomized. Is that correct?
If it's less than 45 and she is feeling well and doesn't get any benefit from driving it any lower in terms of symptom control,
right,
there's no data to say that we're reducing her clot risk anymore by driving it any lower.
Okay. Naveen, do you want to add anything to that?
I agree completely. I think it is coming up frequently, though, the 42 to 45. So personalization for each patient in that range, I think, as Aaron mentioned.
Have either of you read the research about a vaccine for the CALR mutation? Are you familiar with that?
Yeah, I'll take that one for us.
Yeah.
This is a really kind of a amazing story, I think, that kind of came out of nowhere for many of us in the last few years. So to remind everyone, so JAK2 V617F is still the most common somatic mutation recurring in all the MPNs, so almost all, if not all, PV patients, maybe 50 to 60% of our ET and MF. And we used to just say non-JAK2 mutated, and then all of a sudden we have these two other mutations, CALR in 2013, a New England Journal, is the second most prevalent. It's almost unheard of to have it in PV, right? By definition, that should be JAK2, but it'll be in ET and MF, maybe 20, 30% or more of these patients. What's interesting about the CALR, to explain it to folks, is this one, more than the MIPL or the JAK2, looks like it is immunogenic. It can receive and interact with the immune system. That's a kind of a new finding for our MPN field, but scientists have known about it. The second thing is, because it is immunogenic or has these neoepitopes, it has a chance to interact with the immune system. Can we, as scientists and doctors, harness that and activate that system to then attack, you know, the MPN? And so, as you mentioned, yes, our colleagues, so Dr. Anne Mullally in Boston, Dr. Kralovic in Europe, are kind of the two leading forces, and many other groups with CALR in terms of targeting it from an immune. So you're right. So yes, there is work being done for vaccines against this, for CAR T cells, for monoclonal antibodies. So people out there may know about nivolumab and Yervoy, these medicines in melanoma. So these type of drugs and drug approaches. Now, let's emphasize, as we always do in these town halls, this is not ready for prime time. We're talking about still preclinical, Aaron, what you and I might call preclinical, right? So this is still in the idea phase, right, in the whiteboard phase. But what you're asking about is something new and different for our field, because by and large, the immunotherapy drugs that are out there for solid tumors, we've tried some of them in our MPNs. They haven't been as successful so far. So we have some excitement from the science side, but there's a lot to be done before these enter into the clinic.
Yeah.
Aaron, are you good with, I mean, do you want anything to, add anything?
I'm totally good with that. No, yeah, I mean, that's the exciting thing about the calreticulin being so different from MPL and JAK2 is the fact that there is this protein that's can be targeted, right? And it's a new antigen, you know, whether we're talking about vaccines or calreticulin traps, you know, that can suck up all the mutant calreticulin, because it acts as kind of like, it not only can act on the mutant cell like as an autocrine thing where the mutant cell secretes the calreticulin and it gets itself excited, but it can meander over to neighboring cells and get them all activated too. And so I think, you know, not mutated cells and normal cells, right? So I think it opened up this door of totally thinking about this disease in a different, attacking this disease in a very, very different way than what we've been doing with JAK-STAT inhibitors or, you know, other cell signaling directed therapies. This is a whole new way of thinking about the disease for those patients with this particular mutation.
What are your thoughts on treating inflammation in patients with PV or MPNs, but PV specifically? We do have a couple anecdotal stories from some patients that said, you know, I was so sick and started taking anti-inflammatory measures, medicine, but anti-inflammatory diets, which I'm on. And, you know, can you talk about that for a spell here? You know, what are your thoughts about inflammation in our patient?
Yeah, well, certainly inflammation is part of this disease. The mutant cells release these cytokines driving this inflammation, and it goes hand in hand. The inflammation is what is driving a lot of symptoms for these patients. So I think it's tough because a lot of folks will have inflammation for other reasons as well. You know, there is an overlap between autoimmune disorders and MPNs. There's an overlap between arthritides and MPNs. And so it's kind of tough to sort these things out, but you really want to take a holistic approach with a patient and say, okay, what's everything going on? Is there something else we can hit? You know, in terms of, and we know biologically too, when we kind of get down in the microscopic level, that there's a lot of inflammation going on, not just on the macroscopic level with the whole patient, but, you know, within the bone marrow niche of where these cells are living. And so we can think about hitting inflammation in two ways, you know, throughout the whole body, as well as on a very small level to kind of get after the bad clone that's there causing the PV. And there's a lot of folks working on this. You know, we often chit chat with our friend Angela Fleischman, and her lab really focuses a lot on inflammation and these diseases on the microscopic and macroscopic level. I think the challenge for us in the clinic right now is there's not a lot of direct evidence other than the traditional treatments that we use for PV to kind of simmer down the proliferation. thus reducing the cytokine levels and making people feel better. There's not a lot of direct evidence that anti-inflammatory diets or other anti-inflammatory medications outside of steroids and things like that can make people feel better. But certainly, if a measure like an anti-inflammatory diet is safe, you know, you talk to your doctor and say, okay, this is what I plan on doing. This is my game plan here. And they take a look and say, okay, you're going to get all the nutrients that you need. This diet looks safe with all of your medical history. There's no reason not to try it. And there are lots of people who have very positive experiences with those things, with trying these things. And I think that's success, right? It's hard for us as, you know, to make blanket recommendations without large data. And I think that's really where the gap is right now. And I know a lot of groups are looking into that, like trying these diets and trying to gather the data so we can say, okay, for these folks, this really works and we can apply it to this population. So we have anecdote. The basic science is starting to catch up, and we just got to take that next step looking at large populations.
Right.
Naveen, do you have anything to add to that?
Yeah, I think inflammation is going to be one of the big keys for us in the next decade. We mentioned some other ones earlier, but so I love what you're talking about. So right, so Dr. Angela Fleischman and her colleague, our friend, Dr. Robin Scherber, working on this so-called anti-inflammatory diet. The Mediterranean diet is the one that they basically use, and I think, Anne, you know about this very well. So we'll see what those studies show. In addition, they are looking at some pharmacologic and other agents, right? N-acetylcysteine. Again, for our viewers, these are all, you know, very early preclinical, not FDA-approved type things, but looking at things to decrease the inflammation. Of course, people are looking at statins and other drugs that have already been available. Almost all of our patients who are okay are already on a baby aspirin, right, once a day. So there's kind of built-in anti-inflammatory. But the two other aspects to mention here is the so-called CHIP. A lot of our viewers may be asking you about that, Anne. So that's CHIP, CHIP, clonal hematopoiesis of indeterminate potential, or just CH. This is something that could be something big for us in MPN. So this is a pre-leukemic, pre-MPN state. It is something more than just an inflammatory state, because it is considered to be a pre-cancerous, pre-heart disease state. So the concept here is you take healthy patients without a known diagnosis and you do a molecular mutational profile, and they have a TET2 mutation or DNMT3A, whatever mutation, but without a morphologic diagnosis of leukemia, MPN, or MDS. But a lot of those, not a lot, but a significant portion, more than you would expect, do ultimately progress to MPNs, AMLs, leukemia. And the concept is this: when you're in the CHIP phase, which could be a lot of us walking around out there, is there something that we can do to prevent the CHIP, the inflammation from going, to treat it, to just watch it and let it do its own thing? Because many people, it won't progress. So I think I want people to know what that is. And there are CHIP clinics opening up, including at our center and others, to monitor that. And then finally, there are molecular pathways. Aaron mentioned this earlier, you know, alphabet soup time, but NF-kappa B, tumor necrosis factor. So Dr. Angela Fleischman, Dr. Steve O, our friend who's done town halls with us at WashU, the concept is, can you look at a molecular level and then new drugs and new targets to decrease inflammation, either in concert with the JAK inhibitors? Most of this is for MF, you know, initially, or by themselves after the JAK inhibitors haven't worked. You know, a lot of times in PV, as you both know, the research usually starts with myelofibrosis with the more advanced patients and then works its way back. But, you know, some of these things may apply to PV as well. Anne?
Can you tell the audience more about the new Ropepeg interferon drug that is getting very close to approval? And what are your thoughts about this compared to Pegasus? Anything you can share about Ropepeg?
Yeah, I'll start us off here, and
Okay.
I'd love what Aaron has to say. I think this is exciting. This is something that we mentioned in our opening remarks. So ropegylated interferon, or Bezremi as it's known in Europe, now has 5-year plus data specifically in polycythemia vera. That's what I like about it. So not extrapolating from any other disease. Basically what our colleagues, so Dr. Gislinger, Dr. Kalajian, have shown is that you're looking at a drug which really is less frequent than our pegylated or Pegasus interferon. So it's every 2 weeks in the beginning, then it spaces out to monthly. How about that? So that's in contradistinction of weekly. It does appear, they're not tested head to head, right? So you have to compare across studies, but it does look like there's less toxicity and side effects and discontinuations than we're used to in the States with pegylated interferon. So that should mean less autoimmune effects, less flu-like symptoms, et cetera, et cetera. And then I think the big news is that it appears that they're trending towards lower blood clot rates, the allele burden, so that means the molecular mutation level of your disease, JAK2 or CALR, looks to be going down, and many people, the clinical significance is unclear of that, but that's a nice finding. And then that people are able to be on it for 4 or 5 years out, as compared sometimes to interferon where people discontinue. I think the key for us is, will it have to go through rigorous clinical trials here in America, meaning that it would be delayed for years and years and years? Or what we're all hoping for, and appears that there's a signal that maybe based on such positive data, that data can be reviewed by our agencies here and given an approval. So I'm hoping that that's the latter, right? That we can get it here. I think it would immediately impact and maybe even revolutionize the practice, because sometimes in the clinic, the decision between hydroxyurea and Pegasus interferon basically comes down to, I don't want to inject myself once a week, I'd rather take this pill. Well, if this thing may be quote unquote better, less toxic than the Pegasus that we have, this may tip the balance, and it may be modifying the disease more. I would love to see what you and Aaron's thoughts are. Wouldn't it be cool to eventually have a randomized study like we have for Hydrea versus Pegasus, maybe post-approval, to really test these two head-to-head? So hydroxyurea versus Ropeg interferon, maybe even versus the Pegasus interferon, to once and for all answer that. But I'm excited. I'm excited for our patients, and I think it'll give us a new option.
Aaron?
Yeah, thanks, Naveen. I agree completely. It's very exciting. You think about it, here in the United States, there's only one FDA-approved medication for the treatment of polycythemia vera, and it's ruxolitinib. Hydroxyurea is not even approved here in the US for the treatment of PV, and that's what we use. So it'd be nice to have a second drug. So I think, you know, the idea that the responses are more durable was kind of like the take-home point from all the European trials that have been done. I think is really important too. We want PV patients to do well for a very long time, and durability response, I think, is an important thing to think about. I think the kind of payer barriers here in the United States are a big issue with Pegasus, the existing pegylated interferon that we have. It isn't approved, and it's very expensive, and so you usually got to kind of grapple with all the insurance companies in prescribing it, particularly in front line. It's a little bit easier after patients already had hydroxyurea, but certainly in the frontline setting, after you've had that informed discussion of the different treatment options and the patient is really interested in starting it, it could be a challenge. So I think a drug with a label specifically would be an incredibly helpful. And, you know, because I think a lot of patients would be quite interested. And, you know, Naveen, you talked a little bit about the potential for disease modification or turning back the clock. You know, we see patients of variant allele frequencies go down. And again, I mentioned this paper that was presented at ASH from the Cornell group that showed that there may be an improved myelofibrosis-free survival in patients who get interferons versus those who get hydroxyurea. Again, it was retrospective, a single institution. You could, you know, the academics will all get up there and poke tons of holes in it, but it's data nonetheless, suggesting that we are really modifying, potentially modifying disease. I think the other side of that coin is the French study that looked at discontinuing pegylated interferon. So this was a group of patients who all had complete hematologic responses, meaning that on pegylated interferon, their blood counts were normal. And they showed that they could discontinue pegylated interferon in a lot of those patients. And many of those patients, they didn't need to go back on treatment for a while, you know, even years. And in the patients that did need to go back on treatment, they were able to regain those responses by just restarting the pegylated interferon. So like we do in CML, you know, a patient has CML, they go on their tyrosine kinase inhibitor like imatinib or dasatinib, and they go into really deep remission and are in remission for so long, we can actually stop the drug and have a drug holiday where you're not getting any treatment at all, I think is a really exciting prospect. And kind of also really points to this deeper effect that interferons may have on the disease. So this approval would be very exciting because then we'd have a drug that's approved, that does all these things, and has these potential benefits that we could prescribe to people on a regular basis.
We talked a little bit about, or you two talked about a little bit about it, iron deficiency and how you want to reduce the iron, you know, and give the medicine. Can that cause other problems in the patients, you know, in patients? Either one of you, Aaron?
Okay, I'll jump in. So yeah, iron. Yeah, you know, for a low risk patient who's getting phlebotomies, iron deficiency is the goal. Like, we want to make people iron deficient to control their disease. But the problem is iron deficiency comes with baggage. It can make you feel pretty lousy. You can feel tired, run down, achy. The most infamous or famous, if you will, side effect of iron deficiency is this pica thing, where you have the burning desire to eat dirt or ice. So iron deficiency isn't without its downsides. And so anything that we can do to alleviate patients who suffer from iron deficiency, who have polycythemia vera, is a good thing. And the exciting thing about this PTG300 drug that we've talked about a couple of times is that it actually harnesses this pathway of iron deficiency, if you will. The way I think it's easiest to describe it, it fakes the bone marrow into thinking that it's iron deficient when it really isn't. So it acts as a hepcidin mimetic. So it's like fake hepcidin. And hepcidin, if you think about the cells that contain iron, there's a port where the iron comes out of the cells. It's like a hole, or a spigot, if you will. And what hepcidin can do is either turn on or turn off that spigot. So when you're iron deficient, your body really wants that iron from the iron stores. So the hepcidin can negatively regulate this flow of iron outside these cells. But when we kind of fake it out with this fake hepcidin, this PTG300, it's like the body thinks, okay, I'm iron deficient. We're going to let the iron flow into the iron stores and maintain that balance without actually being iron deficient. And so on this clinical trial with this PTG300, all these patients were getting phlebotomies, and all these patients were iron deficient. And you know, once they went on to PTG300, we see the need for phlebotomy drop off, and then all the markers of iron deficiency remit. You know, the ferritins go up and the iron stores increase, and people do feel better. There was a correlation with quality of life and symptom burden there too. Again, very early, just a handful of patients, but kind of exciting. And then from a hematology standpoint, anytime you say hepcidin to a bunch of hematologists, they get all nerded out. It's like saying the USS Enterprise to a bunch of Trekkies. They're all going to get excited. So not only is it exciting for patients because it's a new way of treating them, it gets all the hematologists very exciting in a very nerdy way.
Or new bow tie?
Exactly.
New bow tie.
For sure.
Okay. Look at all I mean, we are getting just inundated with questions, so I'm going to keep rolling. I'm just going to roll here. You know, I'm going to ask you this, even though I think I know the answer. My wife is currently hospitalized for high white blood count, up to 90,000, and is on Jakafi. Do you have any suggestions for her care? I know that's kind of a hard question because you're not the attending physician, but Naveen, do you want to answer that?
Sure. Yeah, as always, Ann, we always remind our viewers, you know, we'll give general advice, you know, personalized, always ask your own doctor. But in general, I think it's important. This actually came up this week in the clinic where, you know, you can have a super high white blood cell count. So let's just tell people about it because that's a lot of what Aaron and I think about. So several categories here. One is when the white blood cell count is high and you have someone who looks great, they're sitting in front of you in the clinic, likely this is more in a chronic situation. What you need is a couple of things. One, you need the differential, or the diff as we call it. There's 5 different kinds of white cells, and the percentages underneath your total white score give you the real story. So those are neutrophils, eosinophils, monocytes, basos, lymphocytes. Those 5 guys should add up to 100%. Usually most of us have predominantly neutrophils, and then the other cells fall in line. If you have something messing up that differential balance, that can be scary or serious. So if you have blasts, a few blasts are okay, but more than a few blasts can mean that something pathologic is going on. If you have more than 20% blasts, that could mean the disease is going into a leukemia state, so on and so forth. Now, within each of those differentials, and they can tell you a story. Too many neutrophils may mean you had steroids recently or an infection. Too many monocytes or lymphocytes, maybe a recent viral infection. So there's a million different stories that your CBC or blood count can tell. So a white count of 90,000 is just kind of the surface of the story. Now, number two, when you're in the hospital and you're sick, the white count being that high can be a very serious signal. It could mean disease transformation. It could mean a very severe infection that's causing the body to have a reaction called leukemoid, like a C. diff infection or an abscess, so on and so forth. Now, outside of our MPN space, there's a million other reasons why the white count can be high. Smoking or some kind of inflammation, recent surgery and trauma, recent car accident, and the white count goes high because it's an acute phase reactant. So I think that's kind of the general principle, is that in addition to the white count, make sure you have a differential, a peripheral blood smear to look at. If you're suspecting disease progression, always confirm with the bone marrow biopsy, and then always think about infection as one of the common causes of an elevated white count.
Did you want to add anything, Aaron, or should I go?
No, I think that's exactly it. You know, you want to know what these cells are and the chronicity of it. Is this something that happened yesterday, or is this something that happened years ago and has been a slow trend? And then, you know, the other symptoms that are associated with the elevated white count. So those are all really important things that help kind of determine what to do next.
How is secondary PV different symptomatically, and the treatment different? Aaron, do you want to go first?
Sure, yeah. So that you get, yeah, that's a great distinction we need to make, is primary versus secondary erythrocytosis. Erythrocytosis is a big fancy word for elevated red blood cell count. So primary erythrocytosis is going to be a result of problems in the bone marrow. It's a primary bone marrow problem. The other word we use for primary erythrocytosis is polycythemia vera. Secondary erythrocytosis is a different thing. The problem is not the bone marrow, it's something else causing the bone marrow to make a whole bunch of red blood cells. So secondary erythrocytosis, a result of, you know, poor oxygenation, for example. So patients with really bad lung diseases often have an elevated red cell count because you need more boxcars to deliver the coal because the boxcars aren't filling up all the way. There are some certain tumors that can secrete erythropoietin, driving up the red cell count. And so secondary erythrocytosis is very different than primary erythrocytosis. That's primary is PV, and that's driven by typically the JAK2 mutation and JAK-STAT activation. So in secondary erythrocytosis, you got to figure out what is the cause, because you usually want to treat the underlying issue, and that generally makes the symptoms better. The symptoms can be overlapping. People can get the kind of ruddy face and the plethora and itchy skin even with secondary erythrocytosis, but really the treatment focuses on, well, what's the underlying cause and trying to remedy that.
Naveen?
I really think this is an important aspect, because in the last 5 years, we had several patients referred for polycythemia vera, and here were the diagnoses. Patient one was taking testosterone injections without telling his spouse or loved ones, and he forgot to tell the prior doctor, and we got it out in visit 2. Okay, so I didn't nail it in visit 1. Oh yeah, I forgot to mention you guys. So we held the test, and he was doing it for weightlifting. It wasn't for a medical reason, and maybe he got it from not a legit source. So that was the answer. So bone marrow biopsy, JAK2 negative. So young patients inquire about those kind of things. Number 2 patient comes to the clinic, hematocrit is 55, 60, bone marrow biopsy negative, JAK2, CALR, MPL negative. The answer was severe obstructive sleep apnea. So that we are finding very frequent in patients with MPN, patients without MPN. It completely mimicked and polycythemia vera. 3 months after getting an appropriately fitting CPAP mask, the hematocrit normalized, period, without a phlebotomy. Patient 3, yes, patient 3 is interesting too. So same thing, secondary polycythemia. This one took me a month or 2 to work up. A young man, a workup was negative for our stuff. The secondary workups were negative. We ended up doing imaging, which revealed a kidney cancer. So renal cell carcinoma or kidney cancer, secreting erythropoietin. So perineoplastic EPO presentation, looks like PV in the clinic. Nope, you're getting too much red cells from somewhere else, easily treated with surgery, patient doing well. So just to build on what Aaron's saying, primary RPV, actually very uncommon, right, in the general population, maybe 4 to 5 out of 100,000. Secondary polycythemia is actually very common, and we need to rule that out in a lot of these patients.
So a lot of people like to know how often they should get a bone marrow biopsy. And I've heard many of you say over the years that if things are changing, of course you should. But some patients feel like they should do it every year. What is your opinion about that? Naveen, do you want to start? And then, oh, Aaron or Aaron?
No, go ahead.
I think, yeah, I think this one, I think most of us agree on this. I think it's the first thing you said, right? So I think in PV for sure, it's just only when there's a status change. There are a couple of situations where people love to get the yearly bone marrow, right? So if you're on a clinical trial, that's one thing. I think sometimes for people's security or comfort, although beware, you do a random bone marrow, be prepared to see random results, right, Aaron? So sometimes the yearly bone marrow may not yield what you think will. So I think for PV, I'm safe to say, no, please don't do a yearly bone marrow. Get one at diagnosis. The WHO does require that. I think it's important. Make sure you don't have myelofibrosis, and make sure you don't have a concomitant multiple myeloma or a CLL, because MPNs do concomitantly have other things going on. But let's not get yearly bone marrows just to make people feel better. Let's reserve that for a status change. Aaron, what are your thoughts?
I completely agree. Yeah, definitely baseline. You want to get a bone marrow for a couple of different reasons. Establish what the bone marrow looks like right now in terms of fibrosis. 2, make sure there are no surprises like an MGUS or a CLL. And 3, get a chromosome. So a third of patients with polycythemia vera can have abnormal karyotype, and you want to know what the chromosomes are at that time. But after that, I think if patients, your blood counts don't come from the sky, right? They come from your bone marrow. And if your blood counts aren't changing, your symptoms aren't changing, your spleen is not changing, your disease is not changing. And doing bone marrows probably aren't going to change what you do necessarily, and could lead to odd things that then you have to explain off. When I remember distinctly as an intern, we would, you're so eager to order all these tests, and I was working with this doc and like, well, what are you going to do when this result happens? And you're like, I don't know. Like, don't ever order a test unless you're prepared to deal with the results. So I think that's a little truth in that, but really, I mean, your blood counts are a reflection of what's going on in the bone marrow. If they are stable, your bone marrow is going to be the same.
So I've been around for a long time in the MPN space since 2004, 2005, and with all due respect to Joyce Niblock, and in fact, their conference was held on the 19th recently. And Dr. Silver argued that low-risk patients shouldn't merely be treated with phlebotomy, but are very good candidates for interferon. Why would you disagree with that position, or what are your thoughts about that? Naveen, do you want to go first?
Sure. Yeah, I'm actually I'm a fan of interferon. I should say that here. I think that sometimes what's old is new again. I think that as Aaron and I are some of the leading younger clinical investigators of the newer agents, that's great. But I'm with Dr. Silver, and he knows that I think interferon has an expanding role in our MPNs. I think that what's really cool to add to this, I didn't mention it in my earlier remarks, but the ropegylated interferon that we've been talking about has actually been tested in exactly this so-called low PV, low risk PV, and it is showing efficacy there, or feasibility, et cetera. So my answer is I agree with Dr. Silver that we need to keep exploring and investigating interferon, not waiting till the more advanced stages of PV. I think that we do have to think about toxicity, because a lot of these patients, as Aaron mentioned, are already going to have a normal life expectancy. And so if you introduce a ton of toxicity when maybe the disease burden is not as bad, so maybe we need to figure out in the low risk patients who are the ones to push for. And then I think with the ropegylated interferon, and hopefully, I'm hoping, we have a drug that's so well tolerated that we can put it forward to low risk patients and modify their disease at an earlier stage. So I say yes to Dr. Silver, and I say let's keep exploring that. Aaron, what say you?
So you say yes to Dr. Silver and no to Dr. Spivak.
And remember, I trained with Dr. Spivak.
And several other.
It's getting dicey here. Is this being recorded?
Don't tell him I said that. No. So I think that, but that's a really important point. All joking aside, is
Yes.
that there is a lot of debate here, because I don't think there is that conclusive study. There's not that conclusive result yet saying that this is or isn't beneficial. We do lots of things in medicine we think are helpful, but turn out not to be. You know, if I can steal from essential thrombocythemia, there's a lot of fervor for lowering platelet counts in low-risk patients with ET for some time. And until the PT1 study came out showing that, yeah, it doesn't do anything for low-risk patients other than make their numbers look better. We don't want to do harm, right? So we don't necessarily want to introduce treatment that could potentially have side effects or do harm. We think interferons are pretty well tolerated and can do some good, but we really want that data. And so until that data exists, there's going to be tension, and there's going to be some people who say yay and some people who say nay. Now, again, full disclosure, I am a big fan of interferon. I think it has a lot of value. But, I think it's an informed conversation with the patient, right? And you say, look, for a low-risk patient with PV, the current guidelines recommend phlebotomies and aspirin, and starting with that as a starting place. And there are ongoing trials in low-risk PV looking at a number of different agents, one being interferons. And there are these potential benefits. It's not been proven yet, but there are these potential benefits. And so I think if you sit down with an individual, you talk about the risks, the benefits, the alternatives, the difficulty you may have with insurance and the copays you may have, and say, this is the big picture for you as an individual, and come up with the individualized care plan, I think is important. And you use all these bits of information, the ongoing trials, what retrospective data exists, what the guidelines are saying, to have that informed discussion with that individual and come up with a plan for them, what fits them the best. And until these large studies are done, I think that's the best we can do. Definitely people feel very passionately about it. That's why Dr. Silver gets up and says these things, and Dr. Spivak gets up and says these other things, and someone else may get up and say something else. And that's, I think, really stimulates academic conversation. But I think practically you just have to you got to work with the person who's in front of you, the patient that's in front of you, and come up with the best plan for them.
And I would agree wholeheartedly, but I do have a couple of comments, because number one, Dr. Silver is a pioneer in interferon studies with MPNs, and God love him for that. I mean, because he's done brilliant work. But I do, pardon my ignorance here, but we produce interferon, correct? I mean, just naturally we produce it. So that's, I would say, what you just said, Aaron, that it goes back to that individualized and specialized medicine with that individual. How do you determine, and we saw this in the early days of Pegasus, and some of the patients that we talked to quite frequently that were on Pegasus, but dosing was an issue, and of course it's not approved for MPNs. Dosing was an issue. The cost is outrageous. Insurance is outrageous. We have people that have children on Pegasus who are doing much better than they were on any other drugs, by the way. But it's just an absolute struggle in with insurances, and it took a long time to convince a physician to give this child, in particular, Pegasus. So I think it's a fascinating area. I agree that I do think interferon has a real high place in this, plays a major role, but we do have to think about everything, Okay, can you comment? I think you did, but let's go back here. Can you comment on the recent publication by Barboui in the Lancet Hematology Journal? The article authors describe Ropepeg interferon use in low-risk patients. We pretty much covered that. Okay.
Right.
So let me turn to page 5 here.
We're only on page 5.
5 of 25.
I thought we were on page 15.
Yeah. All right. So so this person would like to participate in a Ropepeg trial, but they are 65 years old, but in good health, and are there limitations on age in some of these trials, or I know criteria is different for every trial, but are you aware of anything, a 65-year-old patient that is feeling pretty good? And could get into a Ropeg trial?
So I'll be brief and then let Naveen jump in. But yeah, every trial is different. The inclusion exclusion criteria are going to be different. And I think getting back to this, what's best for the individual, what the individual patient sitting in front of you, not every patient is, it may not be the best choice for every patient. Oh yeah, okay, sorry, got a visitor. A trial may not be the best choice for that individual. A standard care medicine might be a better option. So certainly having that conversation with your doc is really, really important.
Okay.
A lot of times age is a factor in PV trials because of what we consider to be high risk versus low risk, even though it's just kind of basically age and thrombosis history. So that may play a factor into it, but there's usually no upper age restriction for a lot of these clinical trials.
Right on. Yeah, and I think, yeah, that's right, because we have to remind folks out there, the median age for PV is actually around that age, right?
Yeah.
So it's actually 68 probably now. So actually, yeah, so that the age alone won't be a problem. Most of our trials don't cap off at a certain age. So, just check. One thing, and let's remind our viewers, there is a public, well-updated site. It's called clinicaltrials.gov, clinicaltrials.gov. It's run by the government, NIH. So freely available to the public. You can actually take a quick look on there. It'll tell you the sites where the study is. Most of these, and I look at it frequently, it will give you the baseline, not eligibility criteria, but it'll say some general information. So you can check on that. You can also email the PI directly. Anybody out there can do it, or just, talk to the doctors before you go. So age alone is usually not for our field. Other fields, it may be different. And also I wanted to say, Ann, quickly, you are so right? So a lot of the stuff we do, we didn't mention, Aaron and I were filling out prior authorizations, appealing with companies. The interferon and MPN and PV is a big thing because it's not technically FDA approved. So what I'm hoping, again, I'm putting a lot of emphasis on this Ropeg today. Gosh, if we actually have an approved agent, Aaron, like you said, this would actually be the first approved interferon product, even though we've been using it for 40 years. So that may possibly help us in our reimbursement and insurance if we have an actual FDA approved drug. So well brought up by both of you there.
So when I was working at the MPN Research Foundation, the founder, who unfortunately is deceased, Bob Rosen, I remember him having horrible sores in his mouth. Okay. And they at the time said it was from the hydroxyurea or whatever medication he was taking at that time. And this person has said, I'm currently having issues in my mouth. Was initially diagnosed with burning mouth syndrome. The thought behind the symptoms is low iron rather than low B vitamins. I'm already taking B12 and is this frequently seen by both of you or either of you in polycythemia vera patients, mouth sores?
Not commonly, actually, right? So I think it is something that it deserves its own workup, exactly as your viewer is asking. So, right. So anytime you have burning mouth, mucositis, I love this. So vitamin workup is actually key, and sometimes we forget that in the malignant hematology or leukemia space. But I love that. So B vitamins. Iron, of course, Aaron mentioned the so-called pica syndrome, where you're kind of feeling like you're thirsty or you want to have, there's stories of people wanting to eat dirt to satisfy that lack of iron. So right. So looking at vitamins and minerals, that's actually a great point. I will emphasize hydroxyurea, though. It is true. Hydroxyurea does cause mucosal breakdown. So it can be ulcers in the mouth. It can be ulcers in the skin, which I actually see much more commonly than in the mouth. So I don't want to discount that. I do see hydroxyurea causing it, but not commonly, but it does happen. And then finally, a third category that's important, Aaron mentioned it earlier, is autoimmune. Let's take a second to remind everyone out there. So much more common in the general population than our MPNs is the autoimmune diseases. So lupus, rheumatoid arthritis. There's a special one called Sjogren's disease, which causes exactly this syndrome, dry eyes, dry mouth. So one plug I can say for our MPN patients at your next visit, because we're blood cancer doctors, we don't always think about autoimmune, and it's not the easiest thing to think about. Ask your doctor, if that's an appropriate workup. So the ANA test is the screening test, and then there's the specific blood tests. Most of these are blood tests, actually. So I would say drug-induced for sure, vitamin deficiency, autoimmune, that's a nice workup outside of the disease itself, which generally does not elaborate. In the acute leukemias, you do very commonly see this, but there it's usually because of the intense chemotherapies.
Aaron?
Yeah, specifically burning mouth is a challenge. I know a lot of ENT docs will see patients for this, and rheumatologists. I am aware of some patients that do have both at the same time, and it's always tough when you just see a couple of patients. Is there truly an association between the PV and the disease, or is this just random chance?
Yeah.
So you would need thorough epidemiologic type studies in order to answer that question, which there aren't great resources and databases to look at burning mouth, and there aren't great resources and databases always looking at PV either. So I think it would be really challenging to understand, is there a true relationship there between the two? But certainly, oh, go ahead.
Sorry to interrupt. One other thing I wanted to say while you guys were mentioning this is one finding I did make is that of herpes zoster or shingles, because sometimes it can reactivate. So like you were saying, Aaron, the burning mouth and MPN, look for the sort of common things. So shingles, neuropathy syndrome. So I'm actually glad you reminded me of that. Very important thing.
So it's definitely, and like you said, the treatments for polycythemia can make it worse, right? So if you have someone with burning mouth syndrome and they go on hydroxyurea and get a bunch of mouth sores, that ain't gonna help. So
I was just going to say, anecdotally, again, two female patients come to mind right away that developed herpes and genital herpes from, they were PV patients that were, taking, I don't know what their medication was at this time. It was a while ago, but a couple situations like that.
Yeah, and certainly, we think about these viral reactivation syndromes when patients go on ruxolitinib and can have reactivations there. And so you definitely want to think about the whole picture again, the individual sitting in front of you. What are all what's the big picture stuff? What are all the things going on, and try to narrow it down. But specifically burning mouth syndrome and PV, I know there are patients who have both, but it's really poorly understood if there is a true cause-effect relationship there.
So recently, this patient experienced a partial loss of vision in one of their eyes and no signs of a stroke. They saw a retinal specialist for extensive testing and discovered that the artery and blood vessels and the optic nerve are swollen with some hemorrhaging. Could PV cause that?
Yes. This is something that was classically described many, many decades ago. So 3 principles here. Principle 1, all MPN, so PV, ET, MF, all 3. It's one of the rare syndromes in the universe that has a risk of both bleeding and clotting in the same exact syndrome, and can happen on the same day, regardless of blood counts, regardless of anything. That's a really scary part of our diseases. So you're on baby aspirin every day to prevent a blood clot, and yet you could have bleeding. Number 2, in ET and PV in particular, because oftentimes MF patients are dealing with other stuff, you can have a perfectly healthy person who can have various eye and brain phenomena. Let's go through them. So one is called a scotoma, which is a little bit more of a benign thing, maybe a quick blurring of the vision or a transient phenomenon, so not associated with any permanent sequela. Number 2, you could have TIA stroke, exactly as they're asking. We know what that is. Or number 3, you can have the very scary emerusas fugax, which has this scary sounding name, sort of the curtain closing over the eye, and can be something in between there. You can have central arterial or venous retinal occlusion. So that's probably what our viewer was reviewed for, to make sure that there's not an actual blockage. Or these can happen on repeated times, leading to scarring and other serious stuff. So for our viewer, they're going to need to see an ophthalmologist probably regularly, maybe once or twice a year to keep track of that. And then the third aspect of all of this is some of the medicines that we use can either make these worse or better. So again, I'll use the example. You're 65 years old, ET, you're on baby aspirin every day, you're preventing yourself from getting a heart attack or a thrombotic stroke, but darn it, now you have platelets are 1.7 million, you're at risk for bleeding from an acquired von Willebrand state, you're on baby aspirin. So these are things that our patients have to watch out for. So a good ophthalmology consultation and follow-up is key. If you need a neurologist, obviously, and then like they said, make sure you're ruling out the obvious stuff like TIA stroke with brain MRI, head CT. But this is something that is seen in our MPN and oftentimes caught too late.
Aaron, anything to add to that?
I think that was incredibly thorough. I
Okay.
concur.
Well, I would just say, this begs the question, how communicative, and I would recommend this to the patient that asked this question, that whoever you go see, if you do go see an ophthalmologist, to make sure that they understand what you have,
Right.
and to possibly consult with your hematologist, because we've seen too many of these situations happen where there's no communication between the hematologist and the other specialists that our patients have to see, which can be not so great for a great outcome for the patient. Let's see, I'm a healthy 60-year-old female just diagnosed with PV. Will phlebotomy plus aspirin lead to myelofibrosis or other serious complications compared to hydroxyurea? What has the higher survival rate for treatment by phlebotomy plus aspirin? I'm not sure about that question, but let's stay with the first part of the question. 60-year-old female, just diagnosed with PV. She's healthy. What should she be okay with just aspirin and phlebotomy or hydroxyurea? I mean, what would you recommend?
Yeah, certainly everyone's situation is a little bit different, but in general, a newly diagnosed patient who's 60, they're kind of on that cusp of low risk versus high risk. As we all age, our risk for blood clots go up, and blood clot risk is additive. So PV plus age plus diabetes plus hypertension plus XYZ, it all adds up. There's nothing magic that happens at 60. It's not like your day before your birthday, your risk is 0, and then the day after your birthday, your risk is 1,000,000. So I really do think it's on a spectrum there, and you gotta have that informed conversation. Long term, we think that as patients age, the risk is high enough where they may benefit from a cytoreductive therapy such as hydroxyurea, interferons, ruxolitinib. But these ages are not absolute. So again, I think it's one of those situations when someone's on that kind of age cusp, you have an informed conversation about what your plan is going to be for the next year or two. Now, there's no evidence that phlebotomies increase or decrease the risk of progression to myelofibrosis. Likewise, there's no evidence to suggest that hydroxyurea increases or decreases the risk of progression to myelofibrosis. Again, we've talked ad nauseum about interferon, so I won't go there. But so I don't know if disease progression necessarily would factor into that discussion, but it's whether or not we want to start hydroxyurea or another cytoreductive therapy at that time.
Naveen, do you have anything to add to that? I can't hear you.
What Aaron's answer kind of brilliantly brings up to me is it's just so fascinating how little disease modification that we've been doing for the last few decades, right? This cytoreductive therapy, hydroxyurea, interferon, really it's kind of based on, right, Aaron, it's more like decreasing your thrombotic risk, I would say. But as the viewer is asking, I don't have anything yet that I know about decreasing the risk of progression of these. Maybe that's why we're so excited about some of these newer agents. Maybe they can do it. But I really want to emphasize what Dr. Gerds said is so important. I don't know that I can decrease the risk of any of these things, but I can follow you closely. We can monitor it. The blood counts can tell the story as we've been talking about here, and your symptoms. And if there's something changed, check it out. If something's changing, get seen and get checked out.
Around the time I was diagnosed with PV, I began having pain in my sinuses. I was on fluticasone for years and noticed that HU helped to reduce the pain, but then switched to Pegasus. I stopped taking the fluticasone, sorry if I'm mispronouncing that, because my CBC is back to normal. However, there was no change in my sinus pain or inflammation. Could high histamine levels be the cause of this? And can I have high histamine levels even though my CBC is normal on Pegasus? Interesting question.
That's interesting. I'll try to take a stab at that, Aaron, for us. I think they're hitting on something, plausible here, which is you know, a lot of our patients with MPN, now this is people in the absence of systemic mastocytosis. So that is a true, real histamine deregulated state. And you do very much see sinusitis and that kind of stuff. But let's just say in our classical patients with PV MPN only, you know, I do see sinus issues from time to time. You're right. You always wonder, is it because the hyperviscosity of the PV? So let's say the hematocrit is perennially high. You know, you want to obviously aim for that to be below 45, as we talked about. But in the patient who's well controlled, it's tough to know if it really has something to do direct or not. I think the second part of it is the pathophysiology we don't exactly understand, but for sure PV can be elevated cytokines. So these are the protein messengers that are going berserk. People can have extreme fatigue and other symptoms, neuropathy even from PV, bone pain. So Dr. Ruben Mesa, our good friend and colleague, has shown repeatedly that people with PV and ET do have a high symptom burden, just like they can in myelofibrosis. So I think that's fine, but I think the question really is, what do you do about it? I still say see the ENT doctor. I think Aaron mentioned that earlier with the burning mouth syndrome. I find the ENT guys, the team members, to be very helpful, mainly because these are non-MPN related but serious issues as we get older. Do you need a sinus surgery? Do you have a deviated septum? Do you need some other kind of nasal rinses? And then, of course, a whole host of these antihistamines, some of which are over the counter. So I think by and large, there's not a direct correlation unless it's hyperviscosity from uncontrolled disease. But I would have an ENT or an allergist immunologist involved.
And again, I just want to reiterate to that patient that I hope they're still with us. Make sure your hematologist is aware of what's going on in that.
That's
and
important.
There's great doctor knows what's going on as well.
And just to build on what you're saying, even something simple as being on a baby aspirin, people forget about that. You know, you're an MPN patient, you're 67 years old. You may forget to tell the surgeon, or they may forget to ask, and you may want to stop that, for example, for a week before. So it's actually really important what you're saying to coordinate with us, even for the most minor of surgery.
Aaron, did you have anything to add?
No, I think that's a very thorough explanation, and you know, I can echo the coordination between different specialists. I think that the nature of medicine in the year 2021 is that everything is so fractioned. There's this idea of a Dr. House doesn't exist. The idea of someone who's a quarterbacking the whole entire team doesn't really exist. And I think, unfortunately, a lot of this falls on patients. You have a doctor that takes care of your blood disease, your sinus disease, your gastroenterologist that does your diarrhea, and there's no real kind of quarterback. Primary care doctors are busy, you know, doing all kinds of stuff and worried about your screening and stuff, but don't really have the bandwidth to like pull all these doctors together and say, okay, we're all going to come together and talk about this. I think that would occur in a perfect world, but it doesn't. So it's really kind of key for the specialists all to communicate. More importantly now, since there aren't these kind of quarterbacks to coordinate everything.
I agree. And if you have trouble understanding some of the information, sometimes it's nice to bring someone along with you, an advocate, whether that's a family member or a friend, a good friend that can take notes and keep track of things for you. I've done it many times, and I mean with family members, parents especially, and it's a lifesaver because you can always tell the physicians exactly what you heard and what was said at other meetings, at other appointments. Okay, I want to ask this question for the sake of PV. Are there any recommendations as physicians from where you sit to the parent on how to inform the schools and how to protect their children that are in an academic, you know, situation where if they get hurt or just anything, any kind of input or anything you would like to recommend to them to keep their kids safe when they're in school. Any thoughts on that? Aaron?
I think I missed. I think you kind of missed the beginning of the question. Is this a?
This is a parent of a child who has PV, and the question is, how did they keep that child safe in an academic and situation at school? Any recommendations to? Yeah.
It's certainly a tricky situation, and every situation again is a little bit different. But you want to respect the child's privacy, but you also want to keep them safe, and so you want to let people know what's going on. And that's always with no matter what you're talking about, that's a fine line to walk. I think having a kind of straightforward and confidential conversation with the student's teacher, I think is a good place to start, because they're going to have the most contact with that individual. I know lots of folks have like med alert bracelets or similar things, like road ID and stuff, where you can put that information on literally put that information on your child. So if they were to have an event, people who are taking care of, first responders taking care of that individual, that child, would have that information readily available. And in terms of activities and other things, for most folks who have well-controlled disease, there's no reason to think they couldn't participate in all activities, whether it's a child or an adult. There really should, for most patients with well-controlled disease, there's no reason to think that they couldn't participate in all these activities. But like you said, you want to have that layer of safety, and so I think, general guidance would be to discuss with the child's teacher, and then I would consider things like a med alert bracelet or a road ID to kind of have another layer of security there.
What about sports that might cause injury, like open sores or blood?
So gladiatorial sports.
Yes.
Yeah, I would avoid swords, large sledgehammers.
But I mean, what would you avoid, like basketball or any kind of sport where you're having?
Yeah, I think, I don't think there would be any necessarily blanket guidelines towards that.
Okay.
I think again, if an individual, whether a child or adult, their disease is under good control, and they have that conversation with their hematologist, I don't see a reason why they couldn't participate in any sport, whether science Olympiad to even full contact sports like football or basketball or volleyball. I think even patients with mild splenomegaly can participate in some contact sports. The splenomegaly that occurs in polycythemia is something that's rather gradual, and so the spleen capsule isn't stretched like, say, when you get mono and the spleen is stretched really quickly. And more likely to rupture. Again, this is on an individual basis and depends on what's going on, and there's a lot of caveat there. So you definitely want to have the conversation with the child's doctor, or if you're an adult, with your doctor before engaging in any physical activity. But outside those kind of little special situations, I think it's definitely a good thing to participate in sports. Activity lowers your cardiovascular risk, your risk for blood clots, and that can only be a good thing, I think.
I was looking for the term contact sports. That's what I was looking for.
Not gladiatorial sports.
Gladiatorial.
Yeah. Let's see. So when I was first in this space, it seemed like mostly men had polycythemia vera. I mean, when we looked at the numbers and looked at what was happening back in those days, I know there are some studies now. I don't know if you are aware of them, that are, good data about gender differences in symptom burden and treatments that women should know. Now, we host a Women in MPN program every year, and we have lots of information about this. But off the top of your head, do you see gender biases in lab guidelines or different practices and attitudes towards symptom burden? Because as you know, we go through a lot of different things: menses, childbearing years, menopause. We just get it all. We get it all, and so a lot of what I hear from women is, I've been having night sweats forever, but first it was perimenopause, then it was menopause, or then it was, it's that time of month for you or whatever. So we know that those things exist in all across the board. But let's get to the first question. What are the numbers now? I know we've kind of seen a tilt to MF. A lot of women having MF, and could either of you speak to like some of the data that's available right now?
So I'll try to address this first. So yeah, I think, um, straightforward bias as well as implicit bias exists everywhere. And I
Yeah.
think that is something that we all need to be aware of and try to continuously do better by. Whether we're talking about, race or ethnicity or gender or what have you. I think it exists everywhere, and that's something we need to recognize and get better at as a society. And it happens in medicine. So some of the examples that you were stating, that for women it's sometimes just written off as, oh, your symptoms aren't really from your disease. I think sometimes on one hand it's a challenge because a lot of the symptoms that occur in PV, ET, and myelofibrosis can be caused by a lot of different things. We've mentioned that before. You think about fatigue. Fatigue can be caused by so many things. Other medications, sleep apnea was one example for secondary erythrocytosis, and other things can cause fatigue. And so you really want to sit down and take a detailed history and go over what are all the possible things, and not necessarily blow off symptoms, but really kind of be thoughtful of them. I think, PV being as described as like, 2-to-1 male predominance for so long, I think kind of was a self-fulfilling prophecy. So you're not, if you think that the incidence is, is higher in a certain population, you may not think about it in other populations. And so you'll never change the story there. And so I think now with better diagnostics, better awareness, we are uncovering disease in not only both men and women, but in younger patients where it's thought not to happen. So I think these things are changing. There may have been age bias there as well. So I think these things are getting better. They're changing these. We still need to be aware of them and not belittle them at all, and really kind of put them out in the forefront.
That's our programs, and I started that program based on this conversation. It'll be our 7th year of hosting that annual women's event. It's very well attended, and we talk about everything. We talk about sexual health. We talk about psychosocial issues. I mean, it's just so important, but I so appreciate you saying this, Aaron, because, and I know, Naveen, I'm sure you would echo what he's saying. And it is across the board. I've had it happen to me many times. But Naveen, did you want to add anything to that?
Really appreciate this discussion, Ann and Aaron. You guys are bringing up some points that, I think previously had either been stigmatized or just not brought up at all. It blows my mind away. So I'm happy that we're having these kind of discussions. I echo everything you said. I would add, if any of my patients are on this town hall or whoever views this later, one thing we talk about in the clinic, usually in the first visit, is I have a line, something where I say, that's why it's called internal medicine. This is not external medicine. And it is, in fact, the young female patient, usually 30s to 40s, maybe 50s, who, you hate to say it, but what they're told by family members, this is not strangers, this is their family members. Why are you going all the way out to that center? You don't look like you have cancer. What are you talking about? It's not external medicine, okay? That's why I have a board certification in internal medicine first, and then you go on into these things. So there is this complete real situation going on in young people, males and females, that they look great on the outside, whatever that means. They're working, they have a family, but they have extreme fatigue, pruritus. We didn't mention that much here. A lot of these patients with PV have intractable itching that prevents them from having love life, a job, a family. It's crazy. You can't even understand it if you're not in our field with our loved ones and our patients. And they get blown off to the point with the local team or whoever they're seeing, to now they start to get either psychological diagnoses, and there's a whole thing there for young patients with MPN because they don't look the part. The second thing we've noticed is that once you start on a therapy program, whether it's Pegasus, Hydrea, ruxolitinib, thankfully most of these programs do not lead to hair loss or large amounts of nausea, vomiting. So our patients don't look like the patients that are portrayed on TV and the movies. And so they don't look like they're having cancer-related side effects. That also is something that just can blow your mind away for any of us involved in the space. And then a third point, what Aaron was mentioning, and you've mentioned many times, there are so many patients out there who are young, who have a diagnosis of MPN, who don't know it because we haven't thought of it yet. At ASH this year, and our colleagues have shown that the JAK2 mutation and maybe the other driver mutations may be present shortly after birth or even in utero, and may be there for decades before the MPN manifests itself. This is a big game-changing discovery, and it suggests what both of you are saying. This is not just a disease of older people or male greater than female predominance. I think we haven't been diagnosing it. I think we haven't been aware of it. And I think as this becomes more and more discussed and studied, we're going to see a rising incidence, not because there's a sudden outbreak of MPN, but because it was there and we weren't recognizing it before.
Absolutely. And we also started the pediatric and young adult program. And, you know, and I remember when I started that, first when I started the women's program, it was poo-pooed by a lot of people that said, oh, you know, you don't have to separate you know, the genders. Well, excuse me, but yes, we did. And it's proven to be, I mean, not that everything needed to be separate, but there were some very specific issues happening in the, with women that were not happening with men. And I'm sure there are very specific. Alison Moliterno at Johns Hopkins did a fabulous study. Yeah. It was back in, I think, 2006 or 7. Yes. And I remember when I read that paper and I thought, this is fantastic, because yes. I was getting these calls from, you know, women, and she in the simplest terms, she said she discovered men seem to suffer more from the chest up, and women from the belly down, you know, I mean, in some cases with MPNs. But anyway, but we, you know, I'm very grateful that we've had the opportunity to expound on these topics, especially about, you know, with young adults and children. Oh my God. I remember the first time I talked to MPN specialists at the University of California in LA, and they had an infant who had MF, and this was that was a long time ago. And I remember thinking, wow, this must be a very isolated incident. But just what you're saying, Dr. Naveen or Dr. Pemmaraju, you know, it's out there. It's here to stay. And so moving right along, how do you know, and this is always the question on every patient's mind, how do you know if someone is progressing? You know, from PV to AML or to fibrosis. Aaron, do you want to take that?
Yeah, you know, I think the simplest way to think about it is there's 3 ways to monitor a patient. We monitor their blood counts, we monitor their symptom burden, and we monitor their spleen. So you got these like 3 domains. And as long as things in those 3 domains are the same, then the disease is likely the same. But when someone is experiencing progression, we usually see changes in all 3 domains. We notice their spleen getting larger. We know their blood counts getting more abnormal or changing from where they've been, and their symptoms changing. You know, maybe more night sweats, or they're having more spleen-related symptoms like early satiety or abdominal pain. So we'll generally see changes in all 3 domains, which kind of corroborate what potentially is going on. And then we often do recommend bone marrow biopsies to fully understand what is going on under the hood there.
Naveen?
Yeah, that's an excellent overview. You're really trying to look, as Aaron was mentioning, patient-centered. So how are you doing? How are you feeling? You're looking at the numbers, the tea leaves, if you will. So the CBC, if it's changing, if there's blasts, these immature cells, or change in the blood counts. And then the physical exam findings, the objective stuff, the spleen and all of that. I think one thing that I hate to remind people about, and you are nicely bringing it up here, is that it's so weird. PV and ET, all the European studies and now our American studies are starting to say, by and large, most people live a quote unquote normal life expectancy, whatever that means, maybe a little bit less for PV, but yet there's still something like a 3, 5, 7% chance that you could develop AML leukemia. And when it arises out of MPN, those are among some of the worst prognosis cases in the clinic. So I just find that to be so difficult for our patients to live with, and that on the one hand, I'm telling you that you have a fairly benign disease, quote unquote, and I'm putting that word benign in quotes, and then yet there's a chance that it can go to a malignant leukemic progression. So I do use the C word. ET and PV are blood cancers. We used to think of them as disorders, MPD, now they're MPN. Almost all of you out there will have one of these big 3 driver mutations, and if you're so-called triple negative, you probably still have one of the other molecular mutations that we mentioned, ASXL1, one of those. So let's think of these as blood cancers, as Dr. Gerds mentioned. Let's monitor together, and let's not forget that there is a chance that maybe decades later, maybe earlier, they could progress. And so it's not to scare anyone, it's just to know your body, know the information that's out there, ask questions to your doctor, and you schedule a visit if you think something isn't right. Don't wait for that 6-month follow-up visit.
Aaron, did you want to add anything?
No, I think that I completely agree. And yeah, just, having that open line of communication with your hematologist is very important.
I agree. And I know you two, I mean, we send patients to you very often because number one, we know you're really good, but you also care and that you're humble and that you will listen. And I loved what you said. I think both of you said this, to combine how the patient feels with the numbers. Because, there was a study done last year or 2 years ago that, what the physician felt or thought was important and what the patient felt and thought was important were two very different things. I think you probably saw that. I think actually Dr. Messa did it, but the idea that, my numbers may be showing something, but I am having all these symptoms and what is it, what's going on. But moving right along, we don't have much more time, but this has been so good. I just so appreciate your time. So and this is something that came up a while ago, this question, would you recommend checking the JAK2 levels periodically instead of just at diagnosis? Is that relevant in your minds?
And this comes up a lot, monitoring JAK2 allele burden.
Yeah.
I think it's obviously absolutely important for diagnostic purposes when you're making the diagnosis, and we talk about that these drugs might lower allele burden here and there. There is some question of what that means long term, and honestly, we use it as a surrogate for disease modification, meaning that we're rooting out disease and turning back the clock and all these preventing progression. But it's just a surrogate, and it's actually not a very well validated surrogate, to be honest. But it's the best we have. And so when we get up at the podiums at the American Society of Hematology annual meeting or the EHA meeting or ASCO, we talk about reduction in variant allele burden. But in all honesty, we don't know what it means necessarily, and it's the best approximation we have for this goal in treatment. But it's just that, it's an approximation. So I would say, monitoring variant allele burden is more on the research exploration side of things than it is useful in everyday care of a patient.
Naveen, would you like to add anything to that?
I agree with this. It's not ready for prime time just quite yet. It's still mainly in the research space, but it is important to note that it is available in the clinical space. So at some of your centers out there, including my own, I am checking it regularly just because it's available. It's there. We don't know yet what the significance is, as Aaron said. Now contrast that, some of you may know someone, or maybe even some of you out there have CML and you've logged into this. So chronic myeloid leukemia, which has been our gold standard, that one, it does matter, where you can check the BCR-ABL abnormal protein at diagnosis. You have that value, you're taking your Gleevec or your related medicine, and that value must come down over time. Boy, we don't have that yet in our MPN. So even though we can start to track the JAK2, as Aaron mentioned, Dr. Gerds mentioned, it's a surrogate, but it's not the definitive end game. What we're hoping in the next 5 to 10 years with these interferon drugs, with these other drugs, is maybe all of this story does come together, that a decrease in symptom burden, spleen, JAK2 or CALR allele burden all tracks, but we don't know that yet, so stay tuned for that research.
For high-risk PV patients with high LDL, do you recommend taking statins, or would you prefer they take something else to lower the LDL that is not a statin? Or nothing?
Aaron, yeah, what do you?
Yeah, I mean, anything you can do to reduce risk of blood clots, whether arterial or venous, I think is important. Again, blood clot risk is additive. And so if a high cholesterol or a high LDL is driving up your risk for arterial thrombosis or blood clots on the artery side of things, and that can be lower with the statin, I would certainly, in conjunction with your cardiologist or primary care doctor, lower your LDL with the statin.
Naveen, did you want to add anything to that?
Right on. I think sometimes the statin drugs, even though they're one of the most commonly prescribed classes, most people know this if you've watched a commercial late at night on TV, but one thing Aaron and I have seen, the liver tests do need to be monitored. So sometimes your chemo drug plus your statin, watch out for your liver tests. And then people can get some pretty serious muscle aches and muscle pains. It's not always common, but that's something to watch out for. But in general, these drugs get along nicely with most of our drugs.
So see how quickly this time flies, at least I think it did. I'm going to ask one more question, and then I to just share some thoughts for the future and for our MPN, especially today, our PV patients, what you think is happening in a good way, what patients can look forward to, what you're seeing in your labs. I mean, anything you'd like to share. But first, let me ask this, and getting back to COVID, just to wind this thing up. It appears that blood clotting can sometimes be a problem if you are diagnosed with COVID-19. And given that PV patients are at higher risk for blood clots, would you say that the JAK2 mutation, let's say, are people who have the JAK2 mutation who are on aspirin and phlebotomy at higher risk of worse symptoms from COVID? Would you say? I know the data's out. I mean, the data hasn't really been collected.
Yeah, I mean, that's the tricky part. And then, so you want to separate out to symptoms from COVID as opposed to just specifically blood clot risk. So there are ongoing trials in general in COVID. People infected with who have the SARS-CoV-2 virus and are having the COVID-19 syndrome. Active 4 is the big one that the NIH is running, and there's data coming out from that now. And actually, part of the trial has been shut down because it was so overwhelmingly positive that anticoagulation can benefit people. And so I think just all people in general were being very aggressive about anticoagulation in patients who have the infection and have the syndrome. And that would ring true for patients with MPNs as well. I'm not sure we would do anything different. There's no data yet to suggest that we do something different for patients with MPN. You would think if blood clot risk is additive and you have an MPN and you have COVID infection and other risk factors, that would all add up to a higher risk of having a blood clot. It doesn't necessarily say you would have other symptoms would be worse, like fevers or cytokine release or these other things. We don't know that. But specifically for blood clot risk, yes, it is a recognized risk factor, and blood clot risk is additive. So you would, logic would dictate that patients with MPNs would have a slightly higher risk of blood clots when they get a COVID infection versus those who do not. And so we definitely want to be mindful of the data coming out suggesting that we should be anticoagulating a lot of these different patients who have COVID-19, or really the COVID-19 syndrome, if you will.
Very good. Naveen, anything to add to that? Okay. So given that, Aaron, we'll start with you. Any last thoughts, or final thoughts for our PV patients?
Yeah, I know we covered a lot of ground today, but I think, again, kind of harkening back what I started with, things now are pretty amazing. We as a society are under duress for a lot of different reasons, from the pandemic to social unrest and these other things, but things are still moving forward for polycythemia vera patients. We're still uncovering new mechanisms of disease. We're still understanding the science of PV and translating those into new therapies. And so I think the really kind of bright spot here is we're still moving forward despite all that's going on in the world. Cancer, heart disease, all these things still happen. PV still happens despite the pandemic. And I think it's really important that we keep soldiering on to make lives better for our patients. And that is happening. And there are new therapies that are on the horizon, which is an exciting advancement for folks.
Naveen?
Well, I just want to say thank you to you, Anne. Thank you, Aaron, my friends and distinguished colleagues here. Lots of hope despite the pandemic and the awful times that we've all been living through in the past year and a half. The three buckets would be that we have clinical trials that are out there that hopefully will result in new breakthroughs. So keep your eyes on that. Number two, achieving phlebotomy free for a lot of you out there. So not having to show up, get a phlebotomy, wait for the result may be particularly important during these pandemic times. And then three, I think the rise of thinking about PV in the lab and translating it to the clinic. So molecular risk, looking at the mutations, chromosomes, Aaron, as you had mentioned, and then can we design either specific therapies or at least monitoring programs around that. And I think the last point here is advocacy is the key. People like you, Anne, and your organization, make sure that we get information to the people who need it the most directly. So go online, Twitter, hashtag MPNSM, myeloproliferative neoplasm, social media, follow the advocacy organizations. Because look, if you have a rare disease, it's not rare to you or your loved one. It's the disease, it's your life, it's what you're facing. So don't take no for an answer, and don't just stop at a simple Google search. Keep looking, keep searching. There's probably someone out there who's working on your exact topic or disease area. So don't ever give up hope. We're someone out there for you.
Well, I know that I suspect that both of you did this during your lunch time and lab time and patient time. And, you know, as always, I cannot thank you enough. We think the world of you. We respect and admire all the work you've done before the pandemic and during the last year. And we really hope we get to see you in person soon. And to our patients also, we hope to be able to see them soon. We're looking at September as our busting loose, you know, depending on herd immunity and how safe it is to do so. And we just want to be together very badly, but this is our next best thing, and it's been wonderful, really. And both of you have participated before, and we'll call on you again because we intend to do these throughout the year. Even when we're able to meet in person, we'll continue to do these programs because they're very well attended, and we know we're reaching patients that would otherwise not be able to attend in person. We're always trying to reach those patients that are in underserved populations. And so all those listening today, if you know somebody that has an MPN that may not be able to speak our, you know, English, or, you know, is having some other challenge that can't reach us, please let us know and we will do our best to help them. And with that, I would like to thank you both again, and to thank all of our sponsors and my staff, Mallory and Kathleen. I couldn't do any of this without them. And so have a good day, and peace be with you. And be safe.
Wonderful.
Thanks a lot, everyone.
Bye, everyone out there.
Bye. And thank you, patients, for being with us. Bye.
All right.